Hello, welcome everybody. Thanks for joining us today. Super happy to have Travis with us and talk about CareAtlas. Know you're there. We can't hear or see you, but please feel free to put your questions in the Q&A or the chat box, and we'll pay attention and get to as many as we can. We got a bunch of folks coming on today. So welcome. Thank you for everybody participating in the Family Office Insights webinars. We're super grateful for you paying attention and participating. If there's others that you think would benefit from what you hear today, we're super happy to put you in touch, put them in touch, and of course you in touch directly with Travis and talk about CareAtlas in more detail. So we're going to go through uh, a little bit of Travis's history, if that's okay with you, Travis, and talk about your origin story a little bit, and then get right into um, the the meat of the presentation today. So
Yeah,
welcome, Travis. Thanks for doing this today.
thanks. Looking forward to it.
All right. So tell us a little bit about your background, and we'll start there.
Yeah, so I grew up in Central Texas. I'm the son of a serial entrepreneur in the healthcare space and went to NYU, studied finance, worked on Wall Street, worked at a hedge fund. And about, I guess, 5 years ago now, I joined a COVID testing startup that ended up bootstrapping and scaling to about 4 million patients. We almost did $1 billion in revenue and kind of woke up about 2 years ago in a position where I was trying to answer the question of, what do I want to wake up and do every day? And CareAtlas is ultimately what I like to say, the idea that my dad has had for the last 30 years, but really thinking in the age of AI, how do we empower patients and reinvent kind of care delivery? So that's the very long story short, but that's kind of how I landed here and ultimately bringing on the core team I used to work with at my prior company to help me scale CareAtlas. So that's been really important, is just getting the right people in the ship and ultimately scaling what is a wonderful idea but needs a little bit of commercial experience. So yeah.
All right, great. Thanks. Is it okay and with you, and is it fair to sort of just outline what the problem CareAtlas solves before we get into the formal presentation?
Yeah, the simplest explanation is so much of data in healthcare today is built around the insurance system. It's episodic. You're generally only within the system if you're within the four walls of a doctor's office or a hospital. And sort of the idea for Care Atlas is how do we sort of invert the system to make it patient centric, make it patient forward, and ultimately use data that patients have about themselves to inform care. And so that's really the goal, is to work with real humans to build relationships with patients to discover anything and everything standing in the way of them remaining happy, healthy, and at home. And so it's really the intersection of human relationships, but then ultimately empowering patients with data that improves care as opposed to feels, again, very episodic and almost manufacturing line in a sense. So, yeah.
And so the human interaction is key, but having AI now as we have it, which is what a great time to be alive, right? Helps the data to give more information about what's important for seniors, right?
Yeah. And the way I'd explain it is with our patients, it's an ever it's a continuous relationship, but at any point in time, what we're trying to flag are the emergent risks, which are usually social determinants of health. And so it's not that we want to ask a question, we're not going to bother the patient and say, do you live alone? Do you live with family members? But over the course of building and kind of curating the conversations, we can enrich the record in a way that feels more human based as opposed to, a survey or things like that. Um, so yeah, it's been really interesting, and there's so much opportunity. One kind of thing on the horizon that I'm really interested about is the ability to actually analyze language itself. So not just the words, but how are they being spoken? What's the intonation? And there's really cool models now today that are actually able to pick up on things like depression or COPD or sleep apnea just by listening to people's voices. And so I just think it's a fascinating time to be building. And there's so much we haven't discovered in terms of what are we missing? Where have we gone wrong in healthcare?
Super cool. If you will allow me, and full disclosure, I'm an investor in this company called Tonewell, which actually takes a 30-second clip on a voice note and can determine a bunch of interesting things as a result. And of
Yeah.
course, it's based on accumulation of data. But so I've seen it in action, is really
Yeah.
what I meant to say.
I
Uh,
view kind of the analogy is with healthcare specifically in terms of if we were to draw an analogy to the oil boom, I feel like right now data is the new oil. And if you can ultimately build the richest data set on patients in the age of AI, that becomes a moat. So yeah, just really, really fascinating times.
yeah, great. All right, let's get into it. Thanks for being here again.
Yeah, of course. So I'll just blast through the slide deck. And really kind of, I think the core message is CareAtlas is about building the AI-powered care coordination layer for rural America. And ultimately, we want our programs to be covered by Medicare, generally free for our partners and our customers, and ultimately focused on delivering outcomes for seniors, with things like avoiding hospital readmissions, ED utilization, acute care episodes, things like that.
And before, I'm sorry to keep on interrupting you. I'm just thinking of questions that others might be
Yeah.
thinking of. Is what's the intention of focusing on what caused you to focus on rural America?
The When you look at kind of our core value proposition in terms of pain points, rural and remote facilities are generally lower margin, higher risk of closure, operationally constrained, financially constrained. And so, in terms of kind of what we're able to bring, it's just a different conversation than a level one academic medical center, generally higher margin, more people, better resources, better density. Um, and so part of it is just, looking at what we provide and where is there the highest value today. So rural and remote is an acute focus, I think, for at least the next handful of years. Over time, sure, we could move into more urban settings, but I just feel the problem is large enough and meaty enough in rural and remote that it made sense to focus there.
Yeah,
Yeah.
great. Thanks for just saying that. Yeah.
Yeah. And kind of, what's the catalyst or where are we at today, kind of with more of the high level healthcare market. So CMS has recently put $50 billion specifically into rural healthcare transformation. I think what they see is the opportunity to kind of, I say leapfrog, where rural and remote can kind of be the first to adopt some of these more proactive, preventative, remote telehealth based services. Um, so that's kind of a massive opportunity when we look at the potential for funding opportunities to scale. We're at the intersection of exactly kind of what CMS is focused on. Um, in terms of, where we're at, we're live, we're serving patients. We've got about 300 patients today, generating about a 50% gross margin. We're already delivering clinical outcomes, and ultimately, with the first large health system we have today, it's about 100,000 patients in terms of addressable market. So we have line of sight to scaling and ultimately really heavily focused on that implementation, making it replicable, scalable, and taking the platform nationwide. In terms of kind of our differentiation, really our go-to-market is focused on the core software platform itself, but then there's a key services component of the care navigators and the clinicians and the people actually providing those services. And that was kind of a gap I had identified. There's a lot of companies that will provide software, they'll provide the call center, but generally they're not considered a clinical partner. So we are our own clinical practice. We can enroll patients, serve them as if they were a PCP. And it creates a much more collaborative clinical relationship with our partners as opposed to a vendor type relationship. Um, And then, yeah, in terms of kind of white space, our core markets today, RPM and CCM, about 4% of Medicare patients are using these. It's slowly crept up the last 4 to 5 years, but they're fairly new programs, generally seeing inflation plus adjustments and real kind of structural, I'll say, backing kind of from payers as well. So, yeah.
Um, how does it work? Like somebody engages with you. Can you just give us the nuts and bolts of
I'll give you
tactically
the
how?
average month in the life of a patient.
Yeah, that would be helpful. Thank you.
Generally, patients are referred to us at point of discharge. So you can think, my mom is leaving the hospital today. We're generally picking up the phone. The hospital is mentioned, hey, CareAtlas is going to help you with transitional care. They've got remote patient monitoring and chronic care management. They make the referral. Essentially, we're enrolling the patient, performing a new patient visit, and that's where we take kind of the abstract, all the information we have on the patient from that referral and say, we'd love to focus on medication adherence and transportation assistance or behavioral health and diabetes management. So that kind of turns, a patient into a clinical program. Essentially, once they've conducted the new patient visit, they have their remote monitoring, either BP cuff or scale. We're generally calling them once or twice a week. And the way I explain it is it's either emergent and acute needs. Hey, your blood pressure spiked last night. Is everything okay? Are you taking your medication? Or it could just be a routine check-in. I see your weight's been stable. That's great. I see you have a follow-up appointment next week. Do you have transportation? Any number of those things. And that's kind of the heavy focus within the first 30 days is what can we do for that patient to prevent them from going back into the hospital? And really, every patient is different, but that's kind of where the intersection of what programs do we want to deliver mirrored with the reality of the patient. Oftentimes, in order to address healthcare needs, social determinants stand in the way. And so a lot of the work we're doing is dealing with family members, dealing with caregivers, coordinating with existing providers, calling the pharmacy to confirm the prescription. Um, all of the various complexities of healthcare, we're ultimately offloading that from the patient. So beyond the first 30 days, a lot of it is coordination with existing providers. We're communicating with the PCPs, we're communicating with the specialists, and ultimately, you can think about it as before CareAtlas, a patient would present at a hospital. They generally have limited information and they're going to kind of put them through the system. Our goal is by the time a CareAtlas patient enters the hospital, we've already referred that patient's information to the hospitalist so they know what's gone on the last 30 days, what was kind of the catalyst for this person coming in, all of that rich context. Um, so yeah, that's kind of the nuts and bolts of it is just the coordination piece, the phone calls, the monitoring, the vitals, and kind of all of the work we do silently in the background as an advocate for the patients.
So, in the absence of Care Atlas, what I mean, I think the need is pretty clear, but what typically happens for, there are some people that take the discharge papers and read them and actually do what they're told, right? And there's others that just put it on the table and that's the end of it. So, in the absence of that, what's the sort of mean of how people behave post uh, uh, leaving the
I mean,
hospital?
it's sort of the Wild West. That was candidly the problem we were originally brought in to address was lack of adherence to care plans. And so generally kind of the before state is patient goes home, they have 60 pages of documents. They may or may not pick up their prescriptions. They might read the first page. And essentially what we're trying to do is get ahead of it, take that discharge document for them, actively working on it. And then when we need the patient, for example, to pick up a prescription, it's already been confirmed, it's been called in, they go in, they pick it up. Before they might not know if the prescription made it to the right pharmacy. Is it even in stock at that pharmacy? So that's sort of the before and after is, a material amount of friction and drop off in adherence to at least having an advocate and an ally and someone working on your behalf to administer, unfortunately fairly complex discharge papers that most people don't read or follow. So yeah.
Yeah, so I think advocacy is probably the right word, but I was thinking more concierge. Like, how cool is it, right? You have somebody that's going to help you because the medical world is arcane to most people, right?
Yeah, and then when you have 20 prescriptions and eight, physicians prescribing them, sometimes the simplest path is a med rec because those eight physicians haven't been speaking to each other. And so we're saying, wait, what does this patient actually need and for what dosage? So how do we thoughtfully de-prescribe them, right? There's those types of opportunities as well.
And so presently, if it's, I don't know, forgive me, Travis, but I don't know what it's called when you are listed to get reimbursed from Medicare or Medicaid or health insurance companies.
Yeah.
Who's paying for this now until that happens?
So it's all Medicare reimbursed. Our primary business model is we get paid for the transmission of vitals, and then we get paid generally in increments of 20 minutes of service. So an average patient would get anywhere from 30 to 45 minutes a month. Some patients need 2 hours, some need 20 minutes. But generally, that's kind of our monetization model is we're billing under existing CPT codes as a licensed clinical practice. Um, and kind of a core piece of our belief is for patients who can't afford our services and the copay, we're willing to waive them. So generally for patients, most of our patients, it's effectively free. We're not allowed to say it's free, but again, as long as they qualify for financial forgiveness, we're not chasing them up. And that's a big piece of access is making it low to no cost for our patients,
Yeah. So
funded by Medicare.
I misunderstood. I didn't think you had those codes, but since you're a clinical practice, I think by default, right?
Correct.
Yeah. Awesome. Thanks for sharing all that.
Yeah, of course. So this slide just provides quick background and context. So as I mentioned before, my core team worked at a company called Fundamentum Health. During COVID, we scaled from a single facility to 13 states, 1,500 employees, 4 million patients over the course of about 2 years. So I've brought on my CTO that I worked with there. He studied machine learning at MIT, which is AI before AI. So
Great.
he's just been incredible in terms of I'm consistently shocked at how quickly he can build things, and we're scrambling to come behind him and operationalize them. Uh, yeah, and then my COO, who was in charge of kind of the frontline staff and managing the 1,500 employees at my prior company, is leading a lot of the more care delivery, patient-facing team members who are kind of our frontline staff. We call them patient-facing team members. Um, and then, as I mentioned, my dad's our chief medical informatics officer and our board certified physician. He's got 35 years of experience working in ERs, two prior health tech exits. And I like to say kind of the mad scientist and the idea guy behind the scenes.
Cool.
Uh, so yeah, and then kind of one big call out is we're working with Interplay. They're a venture firm based in New York. They've been really helpful, focusing on kind of go to market, fundraising, and then a little bit of product strategy as well. And then I've got a handful of fractional leaders who are filling in with areas like patient experience, chief medical officer, customer success, things like that.
Did you go through the Interplay Accelerator
I'm
officially?
actively going through it right now.
Yeah. Sweet. Nice.
Yeah, it's been really helpful because I'm building out our product function and I'm building out our go-to-market motion. So they're a helpful resource. So it's not just me doing everything.
Yeah. Nice.
Um, this is kind of what we'd mentioned earlier in terms of the problem set. I won't kind of regurgitate everything, but the fact is patients are 1 to 2 hours away from facilities, oftentimes without primary care physicians, and they're readmitting, consistently because essentially they have no relationship until they actually need to go into an acute setting. Providers, again, specifically rural and remote, there's a lack of PCPs nationally, but if you bifurcate it urban versus rural, it's much more acute in rural settings. Um, they've been trying to solve it for, a number of years, higher pay, better compensation, any number of things. It's not working. Um, and then, yeah, in terms of health systems, again, if you just look at the regulatory landscape, the reimbursement landscape, more and more rural and remote facilities are closing. And while that's, I'll say, unfortunate, it actually expands our opportunity because more and more people will be living in these care deserts. So yeah. And I think one thing I didn't mention is basically, order of magnitude is there's about 46 million patients who are, actively losing care. And so there are people, as I mentioned, just that over time, this problem becomes more and more acute. And it doesn't look like it's going to reverse,
So
unfortunately.
that 182 hospitals, I mean, I was totally unaware of it. I know that things have been shutting down, but that's a lot.
Yeah.
Seems a
Yeah. And
lot.
a lot of it is, fee for service has been compressed in terms of margin and the inability to move into value-based care. Um, it's a structural issue for
Yeah.
sure.
Are private insurers also willing to reimburse?
So for our primary market is traditional Medicare, and then the secondary focus is Medicare Advantage. The commercial payers, it's sort of hit or miss. Generally, we can and do provide services to commercial payers, but it's generally a more limited, um, less intensive program. Said another way, Medicare usually leads with policy and then it goes to Medicare Advantage and then commercial. So
Yeah,
what I would expect is as there's more clarity on what's working and what's not, the traditional commercial insurers will come in last.
makes sense.
Yeah. Um, Again, in terms of platform, what I call kind of our core database and our core backend is the health quilt. And you can think of it as a combination of comprehensive medical records, vitals, call transcripts, knowledge graph of related family members and contexts, anything and everything we can pick up on a patient. Then the question is, okay, who needs what context and at what point in time from this system? A key piece for that is physicians use EHRs, so meeting them where they are, where we're essentially a, a ride along or a tag along with their existing workflows. A way to think about that is patient walks in for an annual wellness visit. Instead of just looking at last year's, annual wellness visit to prepare, we're saying, hey, here's your one pager of what's gone on over the last year with this patient. Here's what we think you, as this physician, should actually discuss with the patient to move the needle. So ultimately helping coordinate and inform care alongside the existing physicians and practices. How we do that is empowering our care navigators. Those are the people who are placing the weekly phone calls and helping them answer the question of, you know, in very simple terms, which of my patients needs what from me today and why? And that's a lot of the AI is taking various, signal from noise and saying, this patient had, let's say, a 5 pound weight gain overnight and they have CHF. There's probably excess fluid retention. That's a big problem. Let's pick that up immediately and escalate it to a physician versus Mrs. Jones' blood pressure has been managed well. Let's just send her a text to say, kudos, things look great, keep it up. And anything and everything in between. Um, and then again, those conversations are ultimately what inform a lot of the data we're getting and also kind of the potential care gaps or opportunities for us to help coordinate. Um, we've also got remote monitoring of vitals. That's kind of a key piece, cellular enabled, no Wi-Fi required. They take a reading, we receive it, monitoring all in real time. And then ultimately, kind of one of my meta theses is the idea that there's so much admin and I'll say back office and front office friction in the healthcare system. A lot of that has been automated. So chart documentation, billing codes, RCM, kind of all of those things. So essentially, our team is either building software to empower care navigators and clinicians or automating the things that they shouldn't be doing, which is a lot, unfortunately, in
Yeah.
healthcare. Um,
Well, there's been a lot of compression in if I think of it in terms of margin for doctors, right? Like their time is compressed, their margins are compressed. It's a challenge to be a physician. And I'm my immediate reaction to what you said is that some of the physicians might be offended that you're preparing all this stuff for them and giving them recommendations. And on the other hand, they probably welcome it based
Yeah.
on what's going on.
Yeah, and it's sort of we're not telling them what to do, but we're helping guide them along that clinical decision. And that's where we have the ability to understand who is this physician, generally, what do they care about? And instead of saying, hey, look over here, we think you should care about this, it's, let's curate it to that existing physician. And that's a critical point is like we never want to tell a physician what to do, but we ultimately want to empower them with the context they need to make the decision that they would have made anyways. So yeah.
Are they seemingly accepting that so far?
Yeah, I mean, feedback from a chief medical officer we've been working with is they were using an existing solution. And when we showed him what we had built, he was like, wow, you're not just tracking my time and generating a bill, you're helping me figure out what I need to do, not just start, stop a timer and drop a bill. So I think for most physicians, it's a huge positive. If you can know what to do and when to do it and why to do it, yeah, it's interesting. But I mean, that's like every physician in the United States is going to have their own way of wanting to do it. And again, we're not trying to tell them all what to do. We're trying to help guide them along that journey.
Yeah,
Yeah.
totally makes sense.
Um, in terms of kind of, core value proposition for patients, it's generally eyes and ears and a care team that's always available. It's the ability to have a 1 or 2 page document based on all the information we have to say, what's my care plan? What am I working on? What does my daughter or son need to care about when they call and check in on me? All of those things, and ultimately benefiting from not just yet another AI agent on the end of the phone, but a real human being that's informed about them and their care. Um, a lot of it for providers is again the ability to handle clinical escalations. So you could think about it as some physicians want to see every clinical escalation, some want to see only the most acute, but essentially curating and gating, when do we need to loop in this physician and for what? Trying to minimize the noise of all the people that call into the doctor's office and need various things. Again, meeting them where they are, embedding within their existing systems, and empowering care, and again, more of a proactive, preventative, patient-centric data model. And then, yeah, for our health systems, the key kind of benefit is generally these patients historically would get discharged and then either readmit or not. For us, answering the question of, well, why did these patients readmit or not? Is it because they didn't pick up the prescription? Is it because they didn't have transportation? Starting to answer those questions for them. And again, ultimately focused on generating clinical outcomes, whether it's hospital readmission reduction, ED utilization avoidance, but helping them with metrics that impact both reputational but also financial reimbursement. Um, if hospitals have too high of a readmission rate, they have to pay back 3% of their Medicare revenue a year. So that's all margin flowing the wrong direction. And if your margin is 1.5%, that could be your whole margin.
Exactly. It's a big number.
Yeah,
So, so,
Sheridan.
so this 23% versus CMS, is that a real number?
Mm-hmm.
I'm not
So
doubting your number. I'm just saying in the context of you've been able to achieve that number so far.
yeah, we started with the Medicare Big Six, which you can think of as the oldest, sickest multi-chronic patients. We looked back with our initial cohort of about 200 patients and said, what's the expected readmit rate with this comorbidity versus what we delivered? And directionally, that's the initial 23% reduction. So, I mean, it's not surprising that having no core care, going from nothing to something improved it. And now the question is, how materially can we move it and for what populations? So yeah.
Yeah, nice.
Um, This is probably one of my favorite slides. It just kind of goes over our business model. Ultimately, you can think of it as two primary offerings. One of them is software led. So that's kind of the platform program. That's generally traditional software type margins. You're getting paid per member per month. But then the health system or the doctor is billing the care, they're providing the care navigation, they're actually the physician on call. And that's kind of the
Bless
core.
you.
The second piece is sort of our core go-to-market today, which is a full stack clinical partner. That's again where rural health systems, they need not just the platform, they need the care navigators, they need the clinical support. It's a much higher PMPM fee, but because we have the software blended with the labor, your gross margin is kind of blended into the 50 to 60% range. So you can think of that as being a traditional tech-enabled services offering, but ultimately kind of the long game is to move more into the platform, just because it's much more scalable over time. Um, so that's kind of just giving you an overview of where we're at, where we're going, and why they're different. Um, this goes over what we had just mentioned. The key kind of call out here is we're rapidly expanding, and part of the need for the raise is this large West Texas health system. Last year, we had about 1 to 2 case managers who were referring us patients. Into last year, we got the green light to do kind of a full expansion. So we have about 18 to 25 case managers sending us patients. So just top of funnel is kind of rapidly growing in terms of throughput, and opportunity set. So that's a huge, huge kind of catalyst this year is just growing into that opportunity. Um, and that was kind of, again, we were brought in to reduce readmissions. We had a very targeted population. We delivered on that. And now they're saying, okay, where do we go next? Which other populations, with which other diseases? Um, so yeah, that's kind of the most exciting update this year is just rapidly expanding that contract. Um, this is a lot of words, but the simple explanation is we've got a hospital program that's rapidly scaling and deploying. We actually, with this same hospital system, have a contract in place to work with their clinicians in the platform only type model. They sort of learned about what we were doing and ask, who are you? And then eventually we're like, well, can you help us? So we've developed and we're contracting to bring that to their 200 physicians. So it's not just patients leaving the hospital, it's patients between every visit within that system and truly
Nice.
building into that care coordination layer. Um, so yeah, the focus on go-to-market is growing into that system, growing into that regional catchment area, all of the feeder hospitals and systems. And then by the end of this year, identifying kind of the next 2 or 3 opportunities that look similar across the state of Texas or California, or we can technically go anywhere in the US. It just takes a month or two to stand up those operations. Um, and generally, in terms of pipeline, it's a lot of rural and remote health systems, a lot of payers, a lot of providers, multi-specialty groups. So it's generally kind of 4 core ICPs. It's the hospital and health systems, it's the provider groups, it's the payers, and then we also have kind of the other, which would be home health, skilled nursing, kind of all of the other relevant transitions of care.
And the use of funds you'll probably get to, but is it largely personnel to scale?
Yeah, and so I've been overseeing, I'm a CEO, I'm a CFO, I'm our head of product, head of go-to-market. So a lot of it is just, I'm no longer the expert in the room and I need someone who's done a large health system implementation. Um, so yeah, a lot of those are just resources to grow the existing account, staff up to meet demand, an additional engineer to help my CTO. Um, so yeah, it's mostly focused on implementation, scaling, go-to-market, and product.
Got it. Let's see here. Yeah, it's really your anticipated growth is, I mean, I saw the numbers on the per month per fees. So what's this capital raise look like in terms of, is it a convertible note? Have you decided how you're going to do that? Is it equity?
So right now we've got a safe open at an $8 million cap, raising up to 1.5. We've raised 675. We can either close out that safe note or we can move into a priced round, like, fairly agnostic, but primarily looking to close the additional 825 either in the safe or if someone needs to, it could be a priced round.
Is there a something you can share with the audience that you found is a good profile of an investor that
Yeah,
tends to like this sort of thing? Not just that, but your experience, like who's voting with their checkbook profile wise.
yeah. One is I've got a family office out of the UK. I think my background is I'm very, I wear a CFO hat partially, so we're extremely capital efficient. We're extremely focused on unit economics. And I think it's someone who understands kind of the long-term vision, which is we're going to be lower margin initially because of kind of the go-to-market motion I mentioned, where we're tech-enabled services. But the ultimate goal here is to build the platform. But to get to the platform, you need the patients and you need the data and you need the providers. And so I think it's someone who understands the long-term vision and ultimately kind of, I would say, we're not the traditional VC route. I don't think more and infinite capital solves our problem.
Right.
I think it's targeted execution. I think it's scaling to break even and then proactively raising if we want to grow faster. Um, but my goal is to outlast all of the, VC funded companies where as long as our unit economics are rock solid and we're big enough to reach escape velocity, we're default alive. They might have burned all their money and have a lot of great advertising campaigns, but do they have a sound business model? So yeah, I would think it's just people who understand we're early, we're capital efficient, we're kind of not the traditional venture route, but we're, actively building and scaling and need the right partners who want to build for a number of years, as opposed to I candidly don't want like a 2 year exit to private equity or a 3 year flip to a strategic. I'm like, I've got 10 or 15 more years, like, let's sign up for the long haul. So yeah.
Is there something in the offing, and it's not that I know this, but is there, for example, the next product could be a home health car product that has more margins and bigger dollars and could potentially, uh, get to the bottom line quicker?
I think the big unknown and opportunity is how much and when do we lean into agentic AI? The idea being we're starting, heavily and entirely human led, but the question on outcomes and on margin is how much more can we do for either our patients, our providers, or our partners? And that's sort of the wild card in everything because you can do so much more now than you could at such a structurally lower cost. And that's where the simple explanation is a care navigator might cost $35 an hour. The latest, audio only models for agentic AI that are really good are like $5 to $6 an hour. And so that's sort of the question is over time, how much needs to be humans and what are the humans truly doing versus how much do we offload? Because it's not that there will be less human time, it'll be more impactful human time with everything else in the background. So that's kind of hopefully that makes sense.
Yeah, it
That's
does
kind
make sense. Have agentic AI do the stuff that a human can't, meaning it's actually the other way. Have a human do the stuff that agentic AI can't, right?
exactly,
Yeah.
exactly. And it's like an agent could call and confirm a prescription, things that are very formulaic. It's either a yes, no, it's a checkbox, things like that. But having a 15 to 20 minute heart-to-heart conversation, let's not offload that to AI.
Yeah, it's not. I think, I mean, in the bigger picture, Travis, I think that's one of the things that we ought to be hopeful about is that that human element is unlikely to get replaced, and people who are worrying about their jobs uh, might want to focus on, exercising that human element as a way to make money. And, it's a much bigger conversation, but I think that we're a long way from that being replaced.
Yeah. Yeah. And that resonates with me. I think at the core of what I'm building is trying to focus on human to human connection being the catalyst for a lot of the healthcare and medical issues we face. And yeah, I'm not a techno optimist that believes AI agents are going to magically solve every problem we have. I'm like that they're going to force us to reckon with what it means to be human again.
Exactly. I think you're right. Yeah, we've talked a lot about that in other contexts, but I think you're right. What's the time frame? When would you like to wrap up this raise?
My target's the end of the quarter, next quarter, so end of June. Mainly just to go heads down on execution and scaling. So really kind of keeping it open through the end of June. Um, had a handful of good conversations last week at a conference. So, just trying to really be thoughtful with the last 825 and take it from there.
Yeah, so for the audience, if there's any interest and if there's anybody that would like to hear what you just heard or, have this conversation in a meaningful way with Travis, please feel free. We'll make sure everybody gets in touch. But
Yeah,
Travis, is there anything else you want to add?
no, I mean, I feel like the opportunity is massive, kind of the time is now, and I kind of just, yeah, really looking for the right capital partners who are interested in solving rural and remote healthcare in the age of AI, but being human led. So yeah.
Yeah, one more thing I just thought about, and you talked about it in some way. What's the competitor landscape look like? Are they mostly just, keeping track of time and sending a bill?
It's anything and everything from mom and pop shops to a handful of venture and private equity backed companies, specifically companies focused on rural and remote and being a clinical platform. That's sort of the niche that we're playing in. So that's not as crowded of a market. Um, Generally, companies are focused on larger academic medical centers. They're generally focused on, again, just the software or just the call center. So that's kind of how we're thinking about differentiation is zigging when they zag, going more rural and remote, doing it the hard way, being a clinical platform, and knowing kind of, yeah, staying in our lane. I would rather be the biggest rural and remote care coordination platform and have that be our gold star as opposed to pretend like we're something we're not just yet. Yeah.
Yep, totally makes sense. All right. Well, this has been super helpful and thank you for doing it. And we'll make sure we get everybody in touch with you
Yeah, I
and,
appreciate it.
take it from there. Thank you, everybody, for joining today.
Thanks, Arthur.
Till next time. Thanks, Travis.